So I'm going to talk a little bit about sort of a algorithm for depression. Hopefully you'll be able to see the middle of the screen, that we've come up with, sort of sequential steps equivalent to your levels, and some of the evidence for each of the steps as we move towards more and more treatment refractory patients, bringing in data from STAR-D and Argos trials, randomized control trials, and mostly meta-analyses of RCTs, and then talk a little bit about the guidelines and some thoughts. So I have no disclosures, no horse in the race for any of the meds. I think for the sake of time, I'll skip through the boilerplate stuff that everyone knows. One of the first choices we come across in looking at depression and facing a depressed patient is what medication to start with. There's been hundreds of studies looking at that question. I think the Cipriani paper that you brought up the other day, Rajiv, was really, I do a lot of meta-analyses, and this is one of the best meta-analyses I've seen, sort of a multiple trial meta-analysis where they took all the head-to-head comparisons between the second-generation antidepressants and compared them to each other. And then through that, we're able to make inferences on indirect comparisons between drugs that hadn't directly been compared. Doing that, they were able to come up with a rough ranking of all the meds based on efficacy. So the solid line here, the colors don't show up that well, but the solid line is the ranking of the efficacy. The dotted line is the ranking of the tolerability or acceptability. So you can see that there's drugs, like duloxetine and reboxetine that are all the way to the left, so rank worst in both tolerability and efficacy. There are drugs like venlafaxine that have really good or high rankings of efficacy, but sort of in the middle, low end of tolerability. There's ones like bupropion that were very tolerable, but in the middle in efficacy. So in this sort of meta-analysis, that probably the one that came out best was escitalopram, which was really the best in both tolerability and efficacy. And then if cost is a consideration, then sertraline joins that list. It was almost equivalent to escitalopram in both parameters. I think there's been quibbles with this. A lot of commentaries written about this meta-analysis. Some question of whether the indirect method of meta-analysis is accurate, especially for the tolerability side of things. Whether some of the publication bias that's known from industry-sponsored studies came through here. But there's, I think, probably 4 of the 5 best meta-analyses on the initial antidepressants support escitalopram or sertraline as the best drug. A really good Cochrane review came to the same conclusion. So I think there's pretty good evidence.
And Cipriani actually just updated it. It was just published last month.
Oh, really? Okay.
September.
I didn't see that.
More data in addressing the criticism that came up with the same conclusion.
Okay, good. I haven't seen that. I'll have to look for that. But I think the key point is that there are real differences between these drugs. They're not equivalent. There are real differences between the drugs, and not trivial amounts. So I don't know what if you look at duloxetine, which is relatively highly prescribed, and escitalopram, there's a 25% difference in efficacy and a substantial difference in its acceptability. So and there's other ones, even if you take reboxetine out, which is much worse than everything else, there's still significant differences between the drugs. So it's something we might want to consider when we get to our guidelines. So there's been some sort of movement to when you're faced with a really severe case of depression to start with 2 antidepressants instead of 1. They address this in this COMED study that just came out. Essentially, the solid colors are remission, the shadowy ones are the additional response, and the green is monotherapy with placebo, and the other two bars are combination therapies. And in both the acute phase and the longer phase, they didn't find any real difference between any real advantage in response or remission when you started with two medications. So I think this and other evidence suggests that starting with one drug makes sense. They did this in STAR-D. The drug they chose was citalopram, as you guys probably all know, and there was a pretty disappointing initial remission rate, a little less than 30%. Other studies find maybe a little bit higher initial response and remission rate, but certainly more than half of subjects don't respond to an initial antidepressants, even if you choose what Cipriani said was the best one. There's still going to be a substantial refractory group. So in my view, the next obvious step in dealing with the patient is to try to optimize that the antidepressant that they're on. There's growing evidence that there's really poor compliance with antidepressants. One sort of dramatic finding was that only 20% of patients take their antidepressants as prescribed for over a 6-month period of time. So it's worth taking steps as much as possible to try to maximize compliance, if possible, following up prescriptions with phone calls, strategies that use pill diaries and pill counting methods are difficult to implement, but have been shown to increase compliance. It's also, as been talked about before, important to rule out other disorders, bipolar disorder that hasn't been diagnosed yet. In STAR-D, a big problem was the comorbid anxiety disorders that weren't treated. Was a important factor in non-response. There's a cool paper in PNAS by the Nobel Prize winner Paul Greengard's group, looking at or indicating that at least part of the effect of SSRIs is mediated by a pro-inflammatory response in the frontal cortex. This is mostly in animals, and that a lot of anti-inflammatories used to treat chronic pain interfere with that pro-inflammatory response and reduce the effects of SSRIs. And they also looked at, I think actually, the STAR-D data and showed that the response rates for patients on these anti-inflammatories was much lower than the other groups. So, this needs to be confirmed, but there's I think there's reasons to think that looking at patients who are suffering with chronic pain and on NSAIDs and other anti-inflammatories is an important thing to do when you're dealing with depressed patients, and that might be part of non-response. So after optimizing, I think there's a set of treatments that are worth considering that have proven efficacy and work, but don't have really serious side effects. Probably the most important and most talked about is evidence-based psychotherapies like CBT and IPT. We know they work. Unlike adding a second medication, it's pretty clear that adding psychotherapy to an initial antidepressant increases the efficacy across a whole range of studies. And the effects of the psychotherapy are sustained well beyond the end of the psychotherapy, which is different than the medications. Psychotherapies are not as widely available, especially evidence-based psychotherapies, as widely available as we would like. There's been some work in the last few years about online, specifically CBT, online CBT websites. eCouch is one, and there's another one called the Mood Gym, and they've been shown in, there's a nice BMJ article on randomized controlled trials showing the effectiveness of these online CBT websites in reducing depression. So they're not as good as face-to-face therapy, but something to consider when they're not available. A light therapy, specifically when there's a seasonal component, and even some evidence without a seasonal component, is useful. You said that which one? Tallahassee is the second rainiest city in the country or something. So, even in Florida might have some utility. And then the oral supplements. There's been a lot of work recently looking at the supplements. There's been randomized control trials. Terry, do you mind hitting the computer again? Sorry. Supporting SAMe, folate, methylfolate if you want to pay more, and omega-3 fatty acids. Meta-analyses support SAMe and folate pretty strongly. There's been meta-analyses both ways for omega-3 fatty acids, so I think the evidence is a little bit more murky. And the effect sizes are really small, but they seem to have some positive effect with not very much of a negative side effect profile. There's also a lot of work looking at exercise as a sort of augmenting agent. This is a relatively recent study that looked that added on an exercise program after failure of one antidepressant. And the group that was randomized to the 16 kilocalorie per kilo per week, a relatively rigorous exercise program, had higher remission rates 12 weeks out compared to a generally controlled group. So this required a specific and sort of well-coordinated exercise program, not just telling the patient to exercise. So that's not always available, but it seems like it does have an effect, and there's other work pointing in this direction too. So even with all those steps, you're going to have a substantial proportion of patients who still won't have a response or certainly won't reach remission. So the sort of common question at that point is whether to switch from the initial antidepressant, and let's say you started with an SSRI, switch from that SSRI to another medication or to augment. And there's no clear answer, but it makes sense generally to switch if you've had absolutely no response to the initial medication or had intolerable side effects. Other sort of factors pushing towards a switch would be if you're concerned about polypharmacy and potential interactions and concerns about cost. Factors that would push you towards augmenting would be if you had a partial but incomplete response to the initial SSRI and it was tolerated. And then I think for a big part of the direction we go should be determined by the patient's preference. It's more likely to work if the patient thinks it's going to work. So so if we decide to go with the switch route, the question is whether to switch within class or across the class. And to my knowledge, it's been studied by four papers, whether once you started with an SSRI, whether to switch within class or across class. And there's slight evidence that switching across class is more favorable. The NNT here is 22, so it's a pretty small effect, and you might have a little bit more side effects, but it's significant, and there's evidence that switching across class is more effective than within class, though not by much.
What's the NNT for switching in general? So this is the NNT for switching across class versus switching within class.
Yes.
An NNT of about 20.
Yeah.
Well, what about switch itself? What's the NNT for that?
So staying with the same med versus switching.
Right.
I don't know if I can. It's been studied, but depending on what the initial drug is, the numbers are very different from what I've seen. So the numbers are relatively low when the initial drug is escitalopram, venlafaxine. The numbers are much, or the NNTs are much lower if the initial drug was Prozac or Zoloft. I've seen. So I would say the number would probably be, I'm taking a wild guess, but somewhere in the teens overall. But I saw a lot of variation depending on the initial drug.
So the cross-class switch is very important then. because it's comparable to the effect of switching itself.
Yeah, I think so.
Which means it's doubling the likelihood of response if you switch across.
Right. So the meta-analysis found, like I mentioned, a non-significant, but an increase in patients reporting side effects with the across-class switch. So but I think overall this does support the across-class switch. It's important.